So we're going to do a topic that is on systemic mycosis, means all those fungal infections which actually causes systemic disease. So these are the different fungal infections, okay, which causes systemic infections. Number 1 is blastomycosis. Number 2, coccidioidomycosis. Number 3, paracoccidioidomycosis, and histoplasmosis. So they are very, very important because this question can come as a short note or even a long question, okay, or you may be asked individually regarding certain fungal infections. For example, histoplasmosis, it's usually asked. Even in your there was an exam where the clinical question was on histoplasmosis. Okay, so you read it properly regarding the systemic mycosis. They are very, very important. So what are they? Okay, these 4 fungal infections, they are usually caused by dimorphic fungi. What do you mean by dimorphic fungi? It means dual morphology. When they grow at 25 degrees centigrade, they appear as a hyphae form, and when they grow at 37 degrees centigrade or in the human body, they appear as a yeast form. Okay, so they are geographically restricted. It's just the opposite, sorry. When they are 37 degrees centigrade, they are present in the form of fungi, and when they grow at 25 degrees centigrade, they are present in the form of yeast. Okay, they are geographically restricted. They are present as saprophytes in the soil, and the infection is mostly through inhalation from the soil. So if you're going to see the life cycle of this particular fungal species which are causing systemic mycosis, you'll see that inhalation is the primary mode of infection, and they are highly, highly infectious in nature. So coming to the first one, that is blastomycosis. The agent is Blastomyces dermatitidis, mainly in North America and parts of Canada, and they exist as a mold form and a broad-based yeast cells in tissues. Okay, that's why they are known as dimorphic fungi. So what happens? Blastomycosis, pathogenesis, inhalation of aerosolized conidia. So in the host cells, in the host cells, they are converted into yeast cells, not the hyphal forms. Okay, and the yeast cells will disseminate and cause the infection. So in the human body, that is 37 degrees centigrade, they will appear as yeast cells. So the mode of infection is inhalation of aerosolized conidia, and they are converted into yeast cells in the human body. The yeast cells will multiply in the lungs because primary mode of infection is through the respiratory tract. And finally, from the lungs, they are disseminated to different parts of the body by the bloodstream. So if you look at this, okay, in the left-hand side, okay, there's the hyphae of the blastomyces. You can see they are conidia. Okay, you can see they are septate hyphae containing the conidia. So inhalation of this conidia is a primary mode of infection, and when they are inhaled, they go into the lungs where they be converted into the yeast forms. So look at the yeast forms in the lungs in the picture which is labeled 4. You can see that there's budding, isn't it? So that budding is broad-based. You can see it's broad-based, means it's not pinched at the site of the budding. So this is known as a broad-based budding. Okay, so the yeast may continue to colonize the lungs, or they may disseminate to other parts of the body where they affect the skin. They may infect the skin, the bones, the joints, the organs, and the central nervous system. So this is regarding the biology of blastomycosis. Just remember, inhalation of aerosolized conidia is a primary mode of infection. Once they enter the lungs, they are converted into broad-based yeast forms, okay? And they may stay in the lungs, or they may disseminate to other parts of the body, like the skin, the bones, joints, and the central nervous system. So what are the clinical features which are associated with blastomycosis? The primary infection, it may result in a fever, it may result in cough because of the respiratory tract being involved, or it may result in weight loss. And when it goes into disseminated infection, the manifestations become more severe. For example, the pulmonary manifestations, it can be asymptomatic. If the Blastomyces species stay in the lungs, that is okay. They may be asymptomatic in certain individuals, or in immunocompromised individuals, they may be life-threatening. And cutaneous, when they disseminate to the skin, they manifest as a cutaneous form, the commonest form, which is present on the face, on the neck, and hands. And disseminated, they can disseminate to other organs as well, including the bones, even the central nervous system, or even may cause certain miscellaneous manifestations like a laryngeal disease or an osteomyelitis. So these are the certain skin lesions as a result of dissemination of the fungus to the skin. So you can see it's primarily on the face, but can even affect the hands as well as the neck. So laboratory diagnosis, you can collect the different, depending on the site of infection, the samples are collected accordingly. For example, if it affects the pulmonary tract and the manifestations of lung infection, a sputum sample may be collected or a bowel sample. And if there's dissemination to the other parts of the body, like the joints or even to the skin, biopsy samples may be taken, or even pus samples. So once the samples arrive to the laboratory, a direct examination can be done in the form of a KOH mount, that is a potassium hydroxide mount. So what you will see, it is yeast cells, because they are converted into yeast cells in the human body. So they will be present as yeast cells, which is multinucleated yeast cells, double contoured, means they have two types of double contour, means that the wall is comparatively thicker because it is a double walled, and the yeast cells have a broad-based budding. So I've shown you the picture of broad-based budding daughter cells. Whereas when the direct examination is done on a biopsy sample, which has been stained using this Grocott Gomori methenamine stain, or even the periodic acid SIF stain, you'll be able to identify the broad-based yeast cells. So this is the tissue sections from the different parts. So you'll be able to see the broad-based yeast cells, the budding, and even the nucleus. The nucleus, they are multinucleated cells, yeast cells. Now coming to the culture, if we put through the sample through culture, which is actually the gold standard, because you'll be able to identify the different morphology of the yeast and of the mycelium. So you'll keep it at 2 temperatures, because if you're going to expect a dimorphic fungi, you'll be keeping it at 2 temperatures. One is at 25 degrees centigrade and the other at the human body temperature of 37 degrees centigrade. So the incubation will be in 2 types of the temperature. One is at 25, the other is 37 degrees centigrade. And these samples are inoculated in SDA. SDA we've already done before, which is the, excuse me, so sorry. So the culture is being done into at 25 and 37 degrees centigrade. It can be done on a media which is known as SDA media, that is subrod dextrose agar. And the BHIB, you've already encountered this BHIB, that is a brain heart infusion broth when you were doing bacteriology. And incubation period is 2 to 4 weeks, means it's a long incubation period. So when you grow, it means this particular species at 25 degrees centigrade will grow, they'll produce, if you look at the picture A, they'll produce this type of tan colonies, tan colored mycelial growth, which are cottony in type, you can see. And this mole form, when you examine the mole form, that picture B, that is the examination using the lactophenol cotton blue mount. When you examine that, you'll see there's different hyphae. Those lines are the hyphae. and these these oval structures are the conidia. So the conidia are 2 to 10 micrometer. They are actually the infectious part of the fungus. Okay, so the conidia, it may be spherical, it may be ovoid, pyriform, and they are present on short terminal or lateral branches. Okay, so at 37 degrees centigrade, the one which you've incubated at 37 degrees centigrade, they'll produce a yeast cells. Eventually the growth will be pasty type, and if you take the growth and examine under the lactophenol cotton blue under the microscope, you'll see the yeast cells. So you can see the double contoured yeast cells which I've talked about. Okay, it looks like a double walled, and it is broad based budding. Okay, so it's also known as a figure of 8 because of the broad based budding. So this is other pictures. Okay, the electron micrograph picture, you can see the budding yeast as well as the conidia. So other methods of diagnosis are the antigen detection. It can be done on urine or serum, bronchoalveolar lavage fluid, but cross infections can occur with the other fungal disease, especially with histoplasmosis. Okay, and in the antibody detection, complement fixation tests and immunodiffusion can be done, whereas animal pathogenicity, it can be done on mice, guinea pigs, dogs, and hamsters. Okay, but this is actually not required, because if they grow in media, that will be the gold standard of diagnosis. So the treatment is using certain antifungal agents such as amphotericin B, ketoconazole, itraconazole, and fluconazole. So coming to the next one, that is coccidioidomycosis. So there are 2 species which are important to humans, that is Coccidioides immitis and Coccidioides pocadasi. Okay, so they are prevalent in USA and Mexico, and they are also known, and the infection, this coccidioidomycosis, okay, they are also known as San Joaquin Valley fever, because there's some fever which is involved, or even desert rheumatism. So the pathogenesis again is through infection, is through inhalation of arthroconidia. There's a different type of conidia which are known as arthroconidia. These arthroconidia are barrel-shaped conidia, which I'll show you in the picture. And in the host, these arthroconidia, once they enter into the human body, they swell and form spherules. Okay, they swell and form spherules which thick-walled, and inside these spherules, there'll be development of endospores. So these endospores will be released following the rupture of these spherules, and as a result of the rupture of the spherules, that is the reason dissemination will be occurring. Okay, in this case. So coming to the picture, you can see, can you see that the one which is labeled 1, these are the arthroconidia. These are the chains of arthroconidia. Number 2 is the arthroconidia, which are barrel-shaped conidia. So infection is through inhalation of these barrel-shaped conidia or arthroconidia. Once they enter into the lungs, if you look at the picture, picture, okay, that cycle, 5, 6, 7, 8, they'll first they'll develop into spherules. And you can see in the picture 6, in that label 6, you can see there are spherules. Okay, and inside these spherules, there will be endospores. Now these endospores will be released following rupture of these spherules, as shown in picture 7. And as a result of this rupture of these, the endospores being released, they'll be disseminated to other areas of the body, okay, where they can cause disseminated infection. Okay, some of these spherules again may affect different sites, and again that life cycle, they'll continue the life cycle of development into a spherule, and finally there'll be endospores inside the spherule, and there'll be rupture of these spherules which can release these endospores. So these are the picture of arthroconidia. Okay, this is grown at 25 degrees centigrade. Okay, they'll show the morphology of barrel-shaped arthroconidia. Okay, so this is, you can see these are tissue sections. You can see these are the spherules. Inside the spherules, they are the endospores. Okay, So what are the clinical features? Clinical features in asymptomatic in a majority, that is 60%. But when they do cause manifestation, they may manifest in the form of pulmonary infection, dissemination can occur to the skin, which is a commonest form, the bones as well as other organs. They may even cause chronic meningitis, okay, and cause infection in AIDS patients. So infection in immunocompromised is more severe. The manifestations will be in the form of pulmonary, it will be in the form of meningitis disseminated, but it will be more severe in immunocompromised patients. Okay, so 1 to 3 weeks, the incubation period is 1 to 3 weeks after a person breathes in the fungal spores. Okay, 1 to 3 weeks later, the person will develop the manifestations of the infection. So it may be in the form of fatigue and tiredness. It may be in the form of cough, fever, shortness of breath, and even headache, night sweats, muscle aches or joint pain, and rash on the upper body on legs. So you've seen the rash which is happening as a result of this infection, okay, in the skin. So these are the things where the person will manifest. These are the clinical manifestations. So these are the severe form of coccidioidomycosis, where there's cutaneous granulomatous lesion. Okay, these are severe form which results in an immunocompromised patient, and even extension from the skin. Suppose the skin, the pulmonary here in the second picture, that is a pulmonary infection which has occurred, which has finally disseminated to the areas of the skin, causing a large superficial ulcerated lesions. Okay, so laboratory diagnosis, it has to be done in a biosafety level 3 containment because it is highly infectious and the manifestations are severe. So the samples again can be collected depending upon the site of infection, such as sputum, the CSF sample, exudate, pus. A direct examination is done using KOH, or even any of the, for the biopsy samples, you can do periodic acid safe GMS stain, hematoxylin and eosin stain. And you'll get, if you do these stains, these spherules might appear. So these, you can see the spherules, okay, inside which they are endospores. Okay, and in culture, it can be done again in the similar culture media as in case of blastomycosis. It can be done in saccharose dextrose agar, the BHIB, even blood agar in 3 to 5 days. So comparatively, they grow earlier as compared to the blastomycosis. The period of growth is approximately 3 to 5 days, and by 10 days you can actually see the growth. So the mold at 25 degrees centigrade and yeast at 37 degrees centigrade. So you can see in the picture there's a growth of the mold form. Okay, so this is white in structure, and if you look at this, if you do an LPCB mount of this, there will be barrel shaped arthroconidia which are 3 to 6 micrometer in diameter, and this will be apparent in approximately 10 days. So serological test, that is immunodiffusion, complement fixation test, enzyme immunoassays, and animal pathogenicity tests could be done. It can be done in dogs, horses, cattle, sheep, and rodents. Treatment, most of them recover without treatment, but it depends upon the stage of infection. The treatment will depend on stage of infection and the nature of lesion. So if at all they have to be given antifungal therapy, okay, so the choice is amphotericin B and the azoles, okay, like fluconazole, miconazole, etc. So next we come to this third species, that is Paracoccidioidomycosis, and the principal species here is P. brasiliensis. These are geographically restricted to areas of South and Central America, and they cause chronic granulomatous disease. So here the primary is a pulmonary infection, again through inhalation. It is often inapparent, means asymptomatic, but it may disseminate to form granulomas, okay, ulcerative granulomas of the buccal, nasal, and occasionally the gastrointestinal mucosa. So the mode of infection again is the pulmonary infection. It may be asymptomatic in such individuals, but when it disseminates, it forms ulcerative granulomas of the different parts, like the buccal mucosa, the nasal mucosa, and occasionally the gastrointestinal mucosa. So you can see here, okay, that is inhalation of this arthroconidia. It'll enter into the lungs, and from there it'll be converted into the yeast phase. You can see the yeast phase, okay, and as a result of the body temperature, okay, as a result of the body temperature, it'll push it to convert it into a yeast phase. Finally, this yeast may be disseminated to other parts of the body. So in human beings, okay, there's predominance of infection, okay, and predisposing factors. For example, it's more common in males, okay, and the infection will depend upon the inoculum, how much of the arthroconidia is being inhaled. So the infection will depend upon that. It will depend upon individual to individual. So clinical features, infection is subclinical, and the disease, okay, finally the disseminated disease, it can be in the form of pulmonary, oral, and skin lesions. So these are the common sites where this paracocci ideo mycosis is affecting. That is a pulmonary site, oral, and the skin lesions. And it can be of different types, that is acute or subacute, which is also known as a juvenile type. Juvenile type is common. Why it's known as juvenile type? Because it is common in young adults. It is progressive and there's a high mortality. And the chronic form, that is the adult type, okay, it happens more commonly in adults, and it is slow in onset, long lasting, and gradual. Finally, there's a third type which is known as a quiescent or the sequelae type, which is a latent form of the infection. So it can again reactivate at a later stage depending upon the condition of the human body, the immune response of the human body. Okay, so it can be divided into acute or juvenile type, chronic or the adult type, and the quiescent or sequelae, that is the latent form. So for people who develop symptoms, it usually again affects the lungs and skin. These are the primary sites. It can be in the form of lesions in the mouth and the throat, weight loss, swollen lymph nodes, cough, fever, shortness of breath, fatigue, and even enlarged liver and spleen. So these are the mucocutaneous, lymphatic, and visceral. You can see the lymphatic type, okay, on the right side. The lymphatic type is very common in children, okay, so they usually manifest in the form of swollen lymph nodes, okay. So laboratory diagnosis, again, depending on the site of infection, the sputum ball may be collected, a biopsy sample may be collected, okay, and pus sample. So in the direct, that is again the potassium hydroxide or the calcoflow white hematoxylin eosin GMS stain for the yeast cells can be done. So you'll see yeast cells of approximately 2 to 40 micrometer in diameter. So there's a wide range of the size of the yeast cells, okay. It can be as small as 2 micrometer or as large as 40 micrometers. So if you look at this picture of the biopsy sample, you can see that as different size of the yeast cells and even different types of arrangement of the yeast cells. Okay, so this, okay, so the culture is a gold standard. Again, similar types of culture media. It can grow on SDA, blood agar, and BHIB, that is brain heart infusion broth. So it can grow as mycelium or as hyphae at 25 to 30 degrees centigrade, and yeast forms at 37 degrees centigrade. So the mycelium or the hyphae, if you look at the growth in the culture media, there'll be hyphae of 1 to 2 micrometer with intercalary chlamydospores. So there'll be spores which are known as chlamydospores, okay, and the yeast cells, okay, when you examine the yeast cells, it'll consist of oval or globose cells. So the range of the yeast cells, I've already told you, it may be as small as 2 or even as large as 40 micrometer with small buds. So there may be small buds attached to the main yeast cells. Okay, so they are attached by the narrow neck, and the different types of arrangement of these yeast cells are usually seen. So they may be like a mariner's wheel or pilot's wheel appearance, okay, and even a Mickey Mouse appearance. So you can see here, okay, there's a large yeast cell, that is a parent yeast cell, and there are smaller yeast cells which are attached to the parent yeast cells. And on the right side, there's a morphology. As a result of growth at 25 degrees centigrade, this is a mycelial growth, okay, which is cottony, more or less cottony or velvety in morphology, okay. And they'll, if you do an LPCB mount of that, you'll see that there are different types of hyphae. Okay, so you can see the different morphology of the this fungal infection. Okay, you can see the hyphal form and the chlamydospores. Chlamydospores are actually, they are very thick spores. Okay, they are circular spores which are thicker in structure, as seen in the topmost. If you look at the topmost picture, in the pictures there you can see they are circular structures, and these circular structures are known as chlamydospores. So infection is through inhalation of these chlamydospores. And in B and C actually is showing the different types of yeast cells along with the arrangement of the yeast cells. Okay, so here you can see, can you see on the right side? So that is a Mickey Mouse appearance. It's a central yeast, the parent cell is in the center, and there are two smaller cells which look like the ears of the Mickey Mouse. Okay, so mariner's wheel, if you look at all the smaller yeast cells around the parent yeast cell, it looks like a mariner's wheel. So that's why they different types of arrangement in this paracocci idiomycosis. Okay, so here see the different how they are arranged. Okay, so the other modalities of diagnosis are immunodiagnosis. It can be in the form of skin test, which is known as paracocci dioiodin, and serological test. Okay, that is using ELISA methods and the other modalities, as well as animal pathogenicity again. Like it can be done, it can be inoculated in mice, guinea pigs, hamsters, and armadillos. Treatment, it requires prolonged treatment of 6 to 12 months. It's a very long period, and it can be treated using azoles again and amphotericin B. But it has shown promise with even antibacterial agents such as trimethoprim, sulfamethoxazole, and terbinafine. So these are most, cotrimoxazole, that is trimethoprim and sulfamethoxazole, are mostly given in case of immunocompromised patients. Okay. So coming to the last one, that is histoplasmosis. This is very, very important. It is caused by a species, Histoplasma capsulatum. Okay, so it causes intracellular mycotic infection of the reticuloendothelial system. So what you have to remember here is that it causes infection of reticuloendothelial system. Okay, so it has a worldwide distribution. However, the Mississippi, Ohio River Valley in the USA is recognized as a major endemic region, but it is present in other areas such as Africa, Australia, and certain parts of East Asia, in particular India and Malaysia. So this fungal infection is definitely present in India. It's present in the endemic form. Okay, so pathogenesis, how does it occur, this infection? Through again inhalation of conidia or even mycelial fragments. Okay, so even not only conidia can infect, but even mycelial fragments can establish an infection in the human body. So inside the lungs, they are converted to yeast in the alveolar macrophages, because these are primarily fungal infections of the reticuloendothelial system. So once they are phagocytosed by these macrophages, they convert into yeast in the alveolar macrophages in the lungs, and through these macrophages, okay, they can result in dissemination to the other reticuloendothelial system. So the parasitized macrophages resulting in localized granulomatous inflammation, which can result in dissemination to the other parts of the body, that is primarily to the reticuloendothelial system. So you can see here, this is the hyphae. Number 1 picture is the hyphae along with the conidia. Okay, so infection occurs through inhalation of this conidia. They go into the lungs where they are taken up by the alveolar macrophages, but there they are converted into the yeast forms, and from there they can be disseminated to other parts of the body. Okay, and actually, why do they convert into the yeast cells? Because that warmer temperature in the human body actually triggers the change, actually triggers this conversion from the mycelial form into the yeast form. Okay, so this yeast, they are phagocytosed by the immune cells and transported to the regional lymph nodes, and from there they are transported to other parts of the body. So the clinical features, they can be asymptomatic in 90 to 95% of cases, but the manifestations, if they occur, it can be in the form of acute pulmonary, chronic pulmonary, cutaneous or mucocutaneous, and disseminated form. So these are the 4 clinical manifestations of the disease. However, they may be asymptomatic in 90 to 95% of cases. So laboratory diagnosis, it depends on the site of infection. You can collect the sample accordingly. Sputum, bone marrow, lymph nodes, biopsy samples, that is from the cutaneous lesions, or even peripheral blood film can be taken. So in the direct examination using the GMS stain and the PAS stain, there may be small oval yeast cells 2 to 4 micrometer within the mononuclear or the polymorphonuclear cells. Okay, so you can see here. Okay, so you can see these oval structures. These are actually the yeast cells of histoplasmosis. Okay, these are the yeast cells of histoplasmosis. They may be present in the mononuclear cells or the polymorphonuclear cells, and the size is approximately 2 to 4 micrometer in diameter. So there are certain, beware of look-alike organisms in tissue specimens. So when a biopsy sample is taken or when tissue sample is taken and they are stained using using the different stains, there may be certain organisms, okay, which are present inside the reticuloendothelial cells. For example, in the case of Leishmania is a parasite. Okay, so these Leishmania species also, if they are present, these amastigote forms are there of the Leishmania, which are present inside the cells. Okay, when they are present inside the cells, they are very similar to histoplasmosis. Okay, but you can see that there's a projection. Look at the red arrow on the left hand side picture. There's a projection, okay, which is known as a kinetoplast. So we try to look for the kinetoplast in that case. Okay, so because eventually these are the cells which actually infect the same types of cells as histoplasmosis. There's another infection, toxoplasma. However, these tachyzoid form, you can see these are sickle shaped structures which are present in the cells, so they are not very similar to histoplasma. But the main confusion which you're going to be asked is mainly between Leishmania and histoplasma. Whereas histoplasma, look at the bottom picture, the histoplasma has got no kinetoplast. Okay, so here you can see these are the kinetoplast in case of Leishmania. Okay, projecting structures. Okay, whereas in case of histoplasmosis, they are present without any kinetoplast. So the culture may take up to 6 weeks. This also the culture is very prolonged. It can be cultured in SDA and BHIB, again at 2 temperatures, that is 25 degrees centigrade and 37 degrees centigrade. At 25 degrees centigrade, they are white of the buff colony. Buff means it's a buff color, means it's a amber color, it's a light brown color. That is a buff color. So it can be white of buff colonies. The mold form, it produces 2 types of conidia, that is microconidia and macroconidia from short tubular conidiophore. Okay, and the spores with tubercles or finger-like projections is diagnostic. Okay, so these are the picture of the culture. That is a mold form. There are 2 types of conidia. It may be micro, it may be macro, and the spores, okay, with tubercles or finger-like projections is also present. And at 37 degrees centigrade, the yeast cells are produced, which I've shown earlier, and the yeast cell size is approximately 1 to 2 into 3 to 4 micrometer. Okay, so I'll show you the picture here. So can you see here? You can see this is the area, this is the mycelial form. So there are projections that this one, the spores with tubercles or finger-like projections are present, as well as you can see smaller structures. Small round structures, those are the macroconidia, and again smaller than that also, it may be seen in some places, those are the microconidia. Okay, so the macroconidia is usually this rough walled macroconidia with projections. So they are very if you look at them, okay, if you look, they are very diagnostic of the histoplasma species, if such a morphology grows from your mycelial growth in the at 25 degrees centigrade. Okay, so antigen detection can also be done in urine or serum. CSF sample and BAL sample can be collected, but sensitivity is higher in urine than in serum. Okay, particularly for HIV infected persons with disseminated histoplasmosis. So immunodiagnosis, again skin test using this antigen, which is histoplasmin, and serological tests such as immunodiffusion, latex agglutination, and complement fixation test can be done. And animal pathogenicity, it can be done on mice, guinea pigs, hamsters, as well as rabbits. Okay, treatment, prolonged treatment again for this kind of fungal infection, it requires 6 to 12 months. Oral itraconazole is very effective as an antifungal agent, and the other for disseminated infection, amphotericin B is a drug of choice. So that is all regarding this systemic mycosis. What you have to remember is that, okay, these 4 species, okay, these 4 fungal infections, that is, which are caused by blastomyces, coccidioidomyces, paracoccidioidomyces, and histoplasma. These are the 4 fungal infections which are caused by dimorphic fungi. Okay, so this is also very important. Okay, they are caused by dimorphic fungi, geographically restricted. They are present as saprophytes in the soil, and the infection mostly occurs through inhalation from the soil, and they are highly infectious. Okay, so if you're getting a short note on systemic mycosis, okay, please try to write as much as you can. Principally, the principal mode of infection is the same for all the species. You'll have to just remember what are the characteristic feature for the different types of fungal infections. Okay, so that is all now. Thank you so much. Okay,
Thank you, ma'am.
thank you.
Thank you, ma'am.
Thank you, ma'am.